The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and welcome to this webinar on the clinical relevance and detection of vertebral fractures. My name is Masaki Fujita, and I am the Science Project Coordinator at the International Osteoporosis Foundation. I am also the Global Program Coordinator for this program on Capture the Fracture. I am happy to tell you that we have an excellent speaker today, Professor Willem Lems, who is a professor of rheumatology at the VU University Hospital in Amsterdam, the Netherlands. He is also an active member of the CTF steering committee. He is an expert on vertebral fractures, and he will tell you everything about vertebral fractures today. Now, before I begin, I'd like to inform you that attendees are automatically muted. If you have any questions, please feel free to type your questions into the question box. You will find this in the GoToWebinar panel. Now, questions will be collected throughout the webinar, and I will voice them to Professor Willem Lems at the end of the webinar. Now, Professor Willem Lems, please begin when you're ready.
Okay. Thank you, Masaki. Ladies and gentlemen, it's a great pleasure to give a webinar for IOF Capture the Fracture about clinical relevance and detection of vertebral fractures. So these are my disclosures, and the learning objectives for today is to realize the clinical relevance of detecting vertebral fractures in your patients and to know how to diagnose vertebral fractures in your patients. And in addition, if you have access to vertebral fracture assessment, to realize that in all your patients in which a DEXA is indicated, also a VFA is indicated. But before discussing the VFA, or the vertebral fracture assessment, I will start with Capture the Fracture. That's a global flagship program of the IOF. It's launched in 2012, and the mission is facilitating the implementation of FLS to prevent secondary fractures. These are the steering committee. You see some famous members within it: Cyrus Cooper, the president, and Sergio Ferrari, the chair, and also Kasim Javid and Christina Akkerson, who are the co-chairs. So why do we need fracture liaison services? I suppose all participants today know that osteoporotic fractures occur quite common. It's estimated to be around 9 million fragility fractures per year. And remarkably, 80% are not screened and not treated for osteoporosis. That's the fracture care gap, which is an enormous amount of underdiagnosis and undertreatment. And obviously, this leads to a large global health and economic burden, and that can be prevented. So what about the initiative? We want to be the global voice. We want to drive national and international policy. Ensure quality is important, and we want to provide support for FLS, fracture liaison service implementation, getting started and improving and sustaining. So how do we evaluate the effectiveness of an FLS? And that's, in our opinion, by creating standards. So the idea is about the best practice framework. That is the aim of that is to set the standard for the FLS with 13 criteria that will follow on the next slide. And the guidance is translated in several languages, including Chinese, but also Japanese, Russian, Spanish, etc. So these are the main criteria and standards. I don't want to list them all, but to give you some idea, it's about patient identification, about which are the patients and how many patients with a fracture do you have in your hospital. It's about patient evaluation, post-fracture assessment timing, the vertebral fractures in red for today. It's about secondary causes of osteoporosis, about fall prevention, about starting medication, about follow-up of medication, and about the structure of your fracture liaison service, the communication to GPs, and the long-term management. And if you fill in the forms, I'll come back to that later, your FLS service can get a bronze status, a silver status, or a gold status. And bronze is in generally when you are able to identify your patients with when they are not tracked. Silver status, patients identified and indeed adequately tracked. And a gold status if you also are able to independently review your patients. So what are the 5 scoring domains of the initiative? That's of course hip fractures, but also serious other fractures such as pelvis fractures, the large number of outpatient fractures, non-vertebral fractures, wrist fractures, upper arm fractures, and so on. It's about vertebral fractures, and it's about the organization of your FLS. Zooming in onto the vertebral fractures, there are 3 levels. In the lowest level, you are able in your FLS to diagnose vertebral fractures in patients with a clinical vertebral fracture and to prescribe them treatment for prevention of secondary fractures. At level 2, you have patients who are having a non-vertebral fracture who routinely undergo a DEXA. You have also the possibility to do a vertebral fracture assessment to screen for vertebral fractures. And the highest level is if in your institutes radiologists report vertebral fractures when they see a vertebral fracture on a routinely made or for other reasons made X-ray, CT, or MRI scan. I must say level 3 is probably quite difficult. So at the moment we have 308 FLS services worldwide, 39 countries from 6 continents, and we are proud that we are above 300, but of course every new FLS is very welcome. So with at the moment 61 attendings, and probably some of them have an FLS and have not filled in the capture the fracture form, and you are very welcome to do that after my lecture. So what is the idea? You can submit an online application. Step 2 is that your FLS is marked in green on the map while being reviewed by Professor Thierry Thomas from France and by myself and some others from our committee. Then in the end it is scored and recognized on the map. It can be bronze, it can be silver, and it can be gold. And if this is going too rapidly for you, you can check it later on the video. So here you can see the map in which the FLS is marked in green on the map while being reviewed. So there are several sites worldwide being reviewed at the moment, but for me it's and for us it's the more the better. So you can ask the question, why should you join the Capture the Fracture program? And there are several reasons for that. It shows your achievements in your own region. You can learn from the initiative to improve your own service. You get national and international recognition with a gold, silver, or bronze star. And you're part of a global initiative to prevent secondary fractures. Next question, who can participate? In fact, everybody can participate who is working in a coordinator-based model of care. All type of facilities, whether it's from rheumatology, geriatrics, endocrinology, or from GPs, at any stage of involvement and from everywhere worldwide. And here you can see what happens if it's scored. This is, for instance, from Taiwan, where there is someone with a gold standard. Another hospital has green, which is under review, and there is a blue one. So back to the VFA. What were the learning objectives? I told you to realize the clinical relevance of vertebral fractures and to know how to diagnose vertebral fractures in your patients. So this is what we are going to discuss today. We start with 3 clinical cases, and we go on with epidemiology, clinical relevance, and so on. I come back to that this later, but this is the structure of my lecture. So the key question is how to prevent secondary fractures in patients 50 years and over with a recent fracture. And there have been several initiatives for that over the years. One of the first one was making the first fracture the last fracture from ASBMR task force by John Eisman and others. And we have also the Capture the Fracture initiative by Christina Akeson and others from our group. And recently we have the recommendations from rheumatologists and orthopedic surgeons, the EULAR effort recommendation for the management of patients older than 50 years with a fragility fracture. And in general, the starting statement is that in all these patients, a DEXA is advocated to look whether there is underlying osteoporosis, but that's probably not enough. And today, my statement is that if you have a patient in which a DEXA is indicated, for instance, in an elderly patient 50 years and over, also a VFA, a vertebral fracture assessment, is indicated. The second patient I want to discuss is a 65-year-old lady with an upper arm fracture. She has suffered from a traffic accident. Her BMI is 24, no other diseases or drugs. T-score is lumbar spine minus 1.7 and hip minus 1.9. And it is reasonable to conclude that this lady suffers from osteopenia and to suggest a healthy lifestyle with enough calcium, vitamin D, exercise and so on, but not to start with anti-osteoporotic drugs because her T-score is not in the range of osteoporosis, is not below minus 2.5. However, suppose you have a VFA and you find 2 vertebral fractures. That increases her subsequent fracture risk, and then it's reasonable to start with anti-osteoporotic drugs, usually bisphosphonates, of course, in addition to the more healthy lifestyle. So a VFA might change the decision whether or not to treat your patients with a bisphosphonate, particularly in patients with osteopenia. And the third patient I want to discuss with you is a 72-year-old lady who has severe back pain just after lifting a heavy bag. She has been treated with alendronate for 4 years, and her initial DEXA showed a hip score of minus 3.1, and now a vertebral fracture was diagnosed with 30% height loss. And the question is it a new vertebral fracture or an incident fracture? And you can argue then in that case it's a failure of your alendronate therapy, or is it just an old prevalent fracture and there is no failure of therapy? For these cases, it's very helpful if you have an initial DEXA with also an initial VFA. So today we discuss osteoporosis, and we do know that's a disease characterized by low bone mass and microarchitectural deterioration of bone tissue, leading to reduced bone strength and a consequent increase in fracture risk. What about the epidemiology? Why are vertebral fractures so often missed? And we started data about the incidence of osteoporotic fractures, and here you can see that the age-specific incidence of osteoporotic fractures in women and in men is high. It's much higher than those of hip fractures and that of wrist fractures, both in women and in men. It is important to realize that this is about vertebral fractures on radiographs, which are usually 3 times more common than clinical vertebral fractures. And here you can see the lifetime risk, and again, vertebral fractures are more common than hip fractures. And it's important to realize that in an aging population, the percentage of individuals with vertebral fractures will probably even further increase. Here you can see that vertebral fractures are quite common. Here a comparison with heart attacks, stroke, and breast cancer. This is one of the most important slides of my lecture. You can see that not all vertebral fractures are the same. On the upper part of the slide, you can see 3 types of vertebral fractures. Anteplate deformity with a decrease in height in the middle of the vertebra. Wedge deformity with a decrease in the height of the vertebra of the anterior part of the vertebra. And crush fracture when there is a decrease in the whole vertebra. Wedge deformities are by far the most common, around 80 or 90% of all vertebral fractures. In the lower part of the slide, you can see the severity of the fractures. Modest, which is between 20 and 25% height loss. Moderate height loss between 25 and 40%. And severe height loss, more than 40% height loss. This is clinically relevant, since the higher the grade of the fracture, the higher the risk of future fractures. This is a slide from Harry Genent, and in clinical studies, vertebral fractures are scoring to the Genent method, and it's divided in grade 1 mild fractures, grade 2 moderate fractures, and grade 3 severe fractures. So coming back to the question, why are vertebral fractures so often missed? The first thing is diagnosing a vertebral fracture is much more difficult than non-vertebral fractures, but because they are often not related to trauma. Vertebral fractures are often overlooked at radiographs. The diagnosis of a vertebral fracture can be overruled by another diagnosis. And the last one is missing the clinical relevance of diagnosing vertebral fractures. Finally, it's important to realize that only 1/3 of vertebral fractures are symptomatic. That means that the patients are searching for pain relief by their physician, while 2 out of 3 vertebral fractures are regarded as asymptomatic. This is an example of Gelberg study from the United States. 934 women, postmenopausal women. And in this study, vertebral fractures were diagnosed by an expert radiologist from a center in 132 patients. In the local hospital, the fracture was reported only in 65 patients. 23 patients had a fracture in their patient record, and 25 patients were treated for osteoporosis. So in other words, there is a large underdiagnosis and undertreatment. Only 1 out of 5 vertebral fractures are adequately diagnosed and treated. This is not only by the study on Gelbach, this is another study also from the United States by Mayumdar et al. And you see the same pattern of underdiagnosis and undertreatment of vertebral fractures. On this slide, you see just an example of why all these fractures are missed. The radiologist is asked whether there's a pneumonia because of high fever and shortness of breath, and he's looking whether there's an infiltrate, and he's missing the vertebral fractures. So, what are the risk factors for vertebral fractures? That's high age, prevalent vertebral fractures, low BMI, familial osteoporosis, immobility, use of prednisone, and comorbidity. And then the question arises, is physical examination useful in diagnosing vertebral fractures? Well, comparing the actual height with height at peak bone age might be very informative. In patients who have 3 to 5 centimeters height loss or more, that might be suggestive for a vertebral fracture. And it's important to realize that height loss can be up to 10 to 15 centimeters in patients with severe osteoporosis. What are the differences between the clinical characteristics of vertebral fractures and a peripheral fracture? I start with the peripheral fractures. These are nearly always direct after the trauma with severe pain, all or none phenomena, usually not occurring at the same location. and there's no deformity. While in contrast, vertebral fractures may occur without trauma during daily activities, bending forwards, lifting your bags, or that kind of things. Vertebral fractures are painful only in 1 out of 3, while the majority is asymptomatic. Vertebral fractures can be gradual and worsen at the same location, and there is a deformity, there is height loss. So diagnosing a vertebral fracture is more difficult than diagnosing a peripheral fracture. How should you treat these patients? Well, in the acute phase, in patients with severe pain due to vertebral fracture, bed rest may be indicated. Analgesics such as paracetamol, I think you should avoid NSAIDs and morphines. Eventually, you can use low-dose paracetamol and low-dose tramadol, and it's important to start with physical therapy as early as possible. And the other thing is that non-pharmacological treatment is important. Adequate calcium, vitamin D, exercises, stop smoking and limit alcohol intake. And it's important to start with anti-osteoporotic drugs, usually an oral bisphosphonate or zoledronic acid or denosumab. And usually drug treatment is for 5 years. Suppose you have an elderly patient with back pain and vertebral deformity. Is it always an osteoporotic fractures? And the question is, can you list 4 categories of differential diagnosis and some clues characteristic of the other 4? And I will give the answer myself to you. It can be non-specific musculo back pain, which of course in a high frequency in the population. It can be cancer. Sometimes there are other characteristics of cancer like weight loss or fatigue and so on. And the pain in patients with cancer is usually progressive, while the pain in patients with osteoporotic vertebral fractures is usually occurring some weeks and then it's decreasing over time. You must be aware of the possibility of osteomyelitis, and for rheumatology, inflammatory back pain, spondyloarthritis is also into the differential diagnosis. So a vertebral fracture can be caused by osteoporosis, but there is also always a differential diagnosis. So what about the clinical relevance of detecting vertebral fractures? This is about mortality. It's well known that elderly patients with a hip fracture have an elevated mortality of around 30% in the first year, but it's important to realize that the mortality after a vertebral fracture is similar to that of a hip fracture and higher than in the general population. This is just an example from the FIT study, alendronate versus placebo in postmenopausal osteoporotic women. Mortality is increased after a hip fracture and also increased after a vertebral fracture, but not after wrist and other non-vertebral fractures. Obviously, hip and vertebral fractures usually occur in the elderly, and age is a well-known predictor of mortality. This is about the mortality rate that increases with the number of vertebral fractures. So the more vertebral fractures your patient has, the higher mortality risk. What about quality of life? Here data from the placebo group from the MORE study from some years ago, study with RELX event versus placebo. You can see the QOL-FO score in the individuals with more vertebral fractures. You have a higher QOL-FO score, which indicates a lower quality of life. And you can see on the right side on the slide that age is also associated with a lower quality of life. So this slide is important because it shows that more vertebral fractures is associated with a lower quality of life. And this is another way to discuss it. You can see the effects of vertebral fractures on several aspects of quality life in a cross-sectional study: physical function, emotional status, complaints and combined total score. A higher number of vertebral fractures is associated with a larger decrease in several aspects of quality of life. What about back pain? This is a very large study. 9,700 patients were followed for 4 years. You see in the yellow bars the days with modest back pain, and the red bar the days with severe back pain. The highest number of back pain days, around 400, is in patients with clinical manifest vertebral fractures, as expected on the right side of your slide. The lowest number of back pain days was in those with no vertebral fractures over 4 years, 174 days. And remarkably, the number of back pain days was also higher in those with radiological new vertebral fractures, 229 days. So the next thing is the days with limited activity in the same study, and you can see the same pattern. Only 37 of patients without a new vertebral fracture had limited activity, while 95% of those with a clinical manifest fracture had limited activity. And very important, of those patients with only a radiological fracture, 77% had days with limited activity. These data emphasize that radiological fractures also have clinical consequences. So in this slide you can see that the consequences of vertebral fractures are enormous. It can lead to kyphosis, loss of height, bulging abdomen, acute or chronic back pain, in severe cases breathing difficulties, depression, reflux, difficulty with activity of daily living, and the need to use a walking aid. Well, prior vertebral fractures increase the risk of subsequent vertebral fractures. Here you can see that the higher the number of vertebral fractures, the higher the risk of subsequent fractures. This is data from 4 large 3 osteoporosis trials in 2,700 patients. And it's also important that that you realize that there is a rapid occurrence of a second vertebral fracture after an initial vertebral fracture. These data have shown that in 20% of patients with an incident vertebral fracture, a subsequent vertebral fracture occurs already within a year. What about the prior fracture risk? That increases the risk of future vertebral fractures independent of BMD. So not only prevalent vertebral fractures predict subsequent fractures, but also a low BMD. Whether patients have an earlier fracture or not, low BMD is a good indicator, and this is most likely due to the fact that low BMD is a reflection of loss of bone material and loss of bone microarchitecture. So both a prevalent vertebral fracture and a low BMD are important predictors. Another reason to detect vertebral fractures is that they are associated with an elevated future fracture risk. The risk of a hip fracture is doubled, and the risk of future vertebral fracture is increased 4-fold. The risk of wrist fractures is not substantially elevated. Here you can see that a higher number of vertebral fractures is associated with a higher number of subsequent fractures, subsequent vertebral fractures. Hip fracture risk is doubled, but the fracture risk is not changed. And here you can see that the higher severity of the vertebral fracture is also associated with a higher number of subsequent fractures. And again, hip fracture risk is doubled and no changes in wrist fracture risk. Then the issue of morphometric versus clinical fractures. You can see that in yellow that in patients with clinical diagnosed vertebral fractures, but also in patients with radiological diagnosed vertebral fracture, the risk of future vertebral fractures is increased 3 or 4 times. So both types of fractures are important predictors of future vertebral fractures. So how to detect vertebral fractures easily? and reliably. That's the issue. And we're also going to discuss some pitfalls in detecting vertebral fractures and the strengths and the weakness of VFA. Well, I suppose you're familiar to all with this. This is just a simple DEXA with a t-score. Usually we regard the t-score as higher than -1 as normal, between -1 and -2.5 as osteopenia, and lower than -2.5 as osteoporosis, and usually lower than -2.5 is a treatment indication. What about vertebral fractures? Here you see some examples, just to be familiar with the different vertebral fractures. From left to right, a normal spine, followed by a mild vertebral fracture, height loss between 20 and 25%, followed by a grade 2 fracture, and on the right side, a grade 3 fracture, more than 40% height loss. Here you see the differences in fractures at the end plate. I suppose these are mild fractures, height loss between 20 and 25%. And on this slide you can see different types of fractures. 0 is a normal vertebral fracture, grade 1, 20 to 25% height loss, grade 2, 25 to 30% height loss, and grade 3, more than 40% height loss. And again, it's important to realize that the larger the height loss, the stronger the prediction of future subsequent fractures. However, in the past we measured our patients with conventional radiographs, but now we have the possibility to do a vertebral fracture assessment in the same setting as measuring DEXA. And with that technique, we can very reliably measure the heights of the vertebra and diagnose vertebral fractures. So vertebral fracture, it's the use of a fan beam densitometry. That's a step forward to image the lateral thoracolumbar spine for prevalent and incident vertebral fractures. Let's discuss the technique of VFA. Here you can see an example. The computer measures the heights of all the vertebra of your patients and indicates also the percentage of height loss. In this example, you can see that there's severe height loss at the thoracal 12 with a height loss in the front of 39%, so a grade 2 fracture, nearly a grade 3 fracture. But the biggest question is, of course, for today, how does VFA compare to standard lateral spine radiography? And the comparison is important. The radiation dosage is much higher by conventional X-rays. It's 600 microsievert versus 3 to 40 microsievert. For X-ray, usually patients have to come back on a separate visit, while VFA can be done at the same time or at the same measurement time as the DEXA. Generally, the costs for X-rays are higher than for VFA. What about the technique? It's the parallax is quite common in techniques with X-ray, and it's much less common in VFA. But it's important to realize the resolution is better from X-ray than from VFA, and particularly in the highest thoracal spine above TH6, it's better in X-rays than on VFA. So it has some strengths, it has some weakness. We are going to zoom in onto that. So there is indeed some lower resolution on VFA than on X-ray, and there is a poor visualization above TH6 or 2H7, and the question is, how important is that? Here you can see a slide in looking at the prevalence of vertebral fractures on visual radiography just with your eyes. SQ, which means semi-quantitative radiography with conventional radiography, and the VFA. You see that there is a remarkable overlap, and you can also see that fractures at TH4, 5, and 6 are quite uncommon. So VFA is definitely of less quality than conventional radiography above 2 TH6, but the number of fractures is quite low at that location, so that's not a very big problem. And the same is for incidence fractures. Again, the percentage of incidence fractures with conventional radiographs on TH4, TH5, and 2H6 is low. Excuse me. However, the sensitivity of LVA is lower than that of radiographs. You can see for grade 1 fractures, 20 to 25% height loss. You can see in this study that 20% of patients had a radiographically detected vertebral fracture, but only 10 of them were detected by LVA and the other 10 were missed. So the sensitivity for diagnosing vertebral fractures by LVA is lower than by conventional radiographs. What about the accuracy? Well, as mentioned, the sensitivity is lower for LVA than for conventional radiographs, particularly for grade 1 fractures. For grade 2 and grade 3 fractures, it's better and it can be up to 95%. In contrast, the specificity of VFA is quite high and it's around 95% or higher. So what does that mean for clinicians? Here you see some other data that the agreement between VFA and conventional radiograph is quite high, with kappa values about 0.82, 83, so that's quite good. But the question is, of course, what does that mean for clinicians? And then it's good that we have better techniques at the moment. You can see on the left part of the slide the older X-rays, and on the right part the newer, which is definitely somewhat better. Vertebral fractures from the point of the radiologist. It can be, of course, if there is a decrease in height in one of the vertebrae, can be osteoporotic, but there are also normal anatomic variants. There can be congenital abnormalities. There can be degenerative disease. I will show you some examples of that. It can be advantages. It can be Patch's disease. I must see that's not quite often occurring. Scheuermann disease is quite common. Malignancy is always in the differential diagnosis, and there can also be short vertebral height without any end plate deformity. So this is an example of degenerative remodeling and hypertrophy, which looks like a vertebral wedge fracture, but it is not. It is osteoarthritis. This is another example, which is not an end plate deformity, but it's a small nodule. And always important to realize that there is a deformity. Not every vertebral deformity with height loss is an osteoporotic fracture. There is always a differential diagnosis. Then, what does that mean for the clinician? How to interpret the VFA? My point of view is that since the specificity of the VFA is very high, 95% or higher, a completely normal VFA more or less rules out a vertebral fracture. And as a clinician, if you look at the graph on the right side of the slide, if you see that there is no deformity, you can see that in 1 or 2 seconds, you know there is no vertebral deformity in this patient. So that's very important information. However, the sensitivity is not so good. So in clinical trials, I told you already that a height loss of 20% is regarded as a vertebral fracture, according to the Jenon score. However, because of the low sensitivity, the threshold for starting anti-osteoporotic treatment based on a VFA is higher. And we are used to have a more severe threshold, for instance, 1 severe deformity, more than 40% height loss, or 2 or more moderate deformities, 25 to 40% height loss, as an indication for starting osteoporotic treatment. And of course, the situation is sometimes that you don't know for sure whether there's a vertebral fracture on your VFA, then there's still some doubt. And then my statement is that when there is doubt about the presence or absence of a vertebral fracture in a patient in which that influenced the starting yes or no with anti-osteoporotic treatment, conventional X-rays of the spine should be performed because they are still the gold standard. So finally, somewhat discussion on the statement that in each patient in which a DEXA is indicated, also VFA is indicated. This is a study from the Netherlands. We had a guideline some years ago in which we advocated to do VFAs in all patients in which a DEXA was indicated after a fracture in the age above 50. And it's two hospitals, one on the left side, the Vicurie, on the right side, the Maastricht Hospital. You can see the percentage of patients with VFA before the guideline was 4%, and after the introduction of the guideline, 95%, which is quite high. And the number of patients in which we found a new vertebral fracture was only 1% before the introduction of the guideline, because no vertebral fracture assessments were done. And after the introduction of the VFA, we found in 19% of the patients a vertebral fracture, which is of course of clinical relevance. This is a study more in detail. This is the percentage of patients with one or more newly diagnosed vertebral fracture. So this is just a vertebral fracture liaison service in which not only a DEXA was performed, but only a VFA. And you can see that in patients with a hip fracture or in patients with a major fracture, around 20% of these patients have a vertebral fracture. Then the question arises, of course, how important is that? If you find a vertebral fracture in patients with a t-score of -3, then the treatment option is still starting with a bisphosphonates, whether there is a vertebral fracture or not. But in patients with osteopenia, defining of a vertebral fracture can make the difference. So here you can see the percentage of patients with at least a grade 2 fracture, and that's 17% in patients with osteoporosis and 13% in patients with osteopenia and 12% in patients with normal BMD. And finally, you find here the clinical implications. In 30% of patients with osteopenia, we found an indications for therapy because of grade 2 or more vertebral fractures. So this is my pre-summary, not the final slide, but worldwide there is a substantial percentage of vertebral fractures that are not diagnosed by radiologists or not diagnosed by clinicians. It's likely that this contributes to unnecessary pain and suffering and to the undertreatment of osteoporosis. Let's say we are looking at the tip of the iceberg. Identification of patients with a vertebral fractures is important because of the presence of prevalent fracture greatly increases the risk of future fractures. And everybody knows who is a participant of this webinar that we have effective treatment for patients with osteoporotic drugs, bisphosphonates, oral bisphosphonates, IV bisphosphonates, denosumab, and for some patients also teriparatide. So my statement for today is that in each patient in which a DEXA is indicated, also a VFA is indicated, and there are two main reasons for that. Diagnosing one or more vertebral fractures in patients with osteopenia increases the subsequent fracture risk, and that may be crucial for starting anti-osteoporotic treatment or not. And the other point is that having a baseline VFA offers the opportunity to discriminate between incident fractures and prevalent fractures. This is clinically relevant, since incident fractures might indicate treatment failure, while prevalent fractures do not. So what are the learning points for today? To recognize the signs and symptoms of a vertebral fracture, To be aware of the high prevalence of vertebral fractures and its risk factors, we are really looking at the tip of the iceberg. To diagnose a vertebral fracture efficiently, probably with the use of VFA. To know about symptomatic treatment options in the acute phase, and to realize that prevention of subsequent vertebral fractures is crucial. Vertebral fractures with VFA can be now diagnosed in patients in which a DEXA is indicated and performed. So some of the final slides are starting. I thank all the participants for listening to this lecture. Of course, we thank Amgen and UCB who gave an unrestricted grant for this lecture. I thank you on behalf of IOF and the steering committee. We thank you for your participation in the webinar. And of course, if you have additional questions or comments afterwards, you can email Masaki at IOF Bone Health. My statement is clear. In the patients visiting an FLS, not only a DEXA is indicated, but also a VFA. And we're going now to the question and answer session now. And you can also, of course, ask myself later any questions at my email address. So thank you for your attention. This was my slide. Yeah. Last slide, Masaki.
Yeah, thank you very much, Professor Willem Lems, for your presentation, for highlighting the clinical epidemiology, clinical impact of vertebral fractures, as well as underlining why vertebral fractures are often missed. I think it's also important in this presentation we covered the importance of accurately diagnosing VF using DEXA together with VFA. Now, we are moving on to questions and answers because we received a number of questions during the presentation. So Professor Lems, if you would like to begin with the first question. Patients with vertebral fracture often go on to have another vertebral fracture, especially when it comes to compressive fractures. What is the reason behind this, and what is your recommendation on how to make the first break the last?
Yeah, that's a great question. Patients may have a non-vertebral fracture because of osteoporotic bone or because of a fall or both. However, patients usually have a vertebral fracture without any trauma. It's a consequence of vertebral osteoporosis. So if untreated, it's highly likely that other vertebral fractures will follow. And I think the best recommendation on how to make the first vertebral fracture the last is not so simple, because vertebral fractures can be asymptomatic. One of the best options is that general practitioners are aware of vertebral osteoporosis in elderly symptomatic patients when they have acute back pain, particularly if they have risk factors as in the FRAC score, so high age, low BMI, earlier fracture, familial osteoporosis, comorbidity, prednisone, and so on, and that they in these patients perform a DEXA and also a VFA.
Thank you, Professor, for your detailed answer on that question. Now, moving on to the second question. Is there a standardized way to report VFA findings that you can recommend?
Good question. Let's say in my personal experience, the radiologists often report either some height loss or height loss, and I strongly advocate that radiologists also quantify and report the amount of height loss. For instance, Thoracal 8 has a height loss of 22%, and Thoracal 10 have a height loss of 41%. That really helps clinicians. In this example, the fracture of the Thoracal 8 is mild according to Genent, but the fracture of Thoracal 10 is 41%, and that's severe, and that can be an indication for treatment in patients with BMD in the osteopenic range.
Thank you for your answer for that second question. Now, going on to the third question now. In your opinion, what do you think are the issues behind DEXA plus VFA reimbursement? I am sure that in some countries, this could potentially be an issue.
Yeah, that's certainly an issue. And let's say that's a good but sometimes difficult question. I think it differs from country to country, but I have some examples, and I'm not an expert in costs. But for instance, in the United States, there is the so-called crisis in osteoporosis, underdiagnosis and undertreatment, and it has many reasons. But one of the reasons is the reimbursement for DEXA is going down from, let's say, above $100 to only $35. And I can understand that also performing a VFA and a DEXA for only $35 is a difficulty. And that's one of the reasons for the crisis in osteoporosis in the US. Not all the most important, but one of the reasons. And in some other countries, for instance, the Netherlands, the reimbursement is much better. It's above €100. And if you get more than €100 for a DEXA, it's more easy to perform both a DEXA and a VFA for that money. But there is something extra. We have in the Netherlands VF also incorporated in our local guidelines. So if you do only a DEXA and not perform a VFA, that's suboptimal diagnostics in our country. So it's one thing about the money. It's the other thing is you should have VFA in your local guidelines.
Thank you for your answer. It seems like there's a lot of value in incorporating VFA into the clinical recommendations. So going on to the next question, the more VFA you perform, the higher number of osteopenic patients with vertebral fractures you may capture. Now, how do you consider the best way to spread the need among physicians of performing more VFA tests in osteopenic plus osteoporotic patients?
Yeah, that's the key question, and my answer is very clear. In all individuals, whether there's an indication for DEXA because of an earlier fracture above 50 years, or in patients with several clinical risk factors with the FRAX, or in patients who are using prednisone, if there is an indication for DEXA, there is always also an indication for VFA.
Thank you, Professor, for your answer. Now, we will have time for a few more questions. So, because this is a CTF webinar, and also you kindly introduced the importance of FLS. Now, in your opinion, how does an FLS improve diagnosis, management, and treatment of vertebral fracture patients?
Yeah, that's of course an excellent questions. I suppose that in all patients with a recent fracture at FLS, a DEXA is performed of the lumbar spine and of the hips. My statement is very clear. You should also perform a VFA in these patients. Of course, it's possible that in your hospital where you're working, no VFA is available. And then it's not necessary to buy a new DEXA machine, but you need only some additional software, which is not so very costly. And the two most important advantage if you have the additional software is, of course, that you can diagnose vertebral fractures in patients with osteopenia, which differs from no indications for treatment because of osteopenia, to on the other side, start anti-osteoporotic treatment because of vertebral fractures. In my lecture, I showed in Maastricht, in the Netherlands, that occurs in 30% of their FLS patients. And the other thing is, of course, that you can later in the course of the disease differentiate between a new incident fracture, and then the discussion arises if you have a new incident fracture, is it a treatment failure or not? Or it can be an already existing prevalent fracture, and then it's of course no treatment failure. But it is only possible to find a prevalent fracture if you have a baseline value. So that are the two main advantages of having a VFA, and the baseline value is of course important for comparing it with later VFAs, which can also be an indication in some countries for starting with treatment with teriparatide. If you have new fractures during therapy, that can be an indication for anabolic therapy.
Thank you, Professor, again for the detailed, elaborate answer. Now, unfortunately, we are coming to the very last question for this webinar. So, If you do not have access to DEXA and VFA because of resource limitation, what would you recommend? Would you recommend conventional radiography, including lateral spine X-ray, or even CT, MRI?
Yeah. My answer is conventional radiographs. In fact, conventional radiographs, the lateral ones, are the gold standard for detecting vertebral fractures, and thus even better than VFA. However, the radiographs are limited by their higher cost and the radioactivity, which is also important. I can also add that in patients in which you know that their height at peak bone mass is decreased by 5 centimeters or more, that they're highly likely to suffer from a vertebral fracture. So in some situations, physical examination may be helpful, but in the majority, physical examination is not helpful. In my opinion, CT and MRI are very expensive, and we only use that when there is a doubt, when there is an osteoporotic fracture or another disease, particularly when there is probably a malignancy. And finally, if you have no access to VFA and also no access to DEXA, you can still have clinical risk factors like age and BMI, and if you do a FRAC score, you can also make some estimation about the fracture risk.
Thank you, Professor, for your answer to the final questions. Now, unfortunately, we've come to the very end of this webinar, so I would like to thank each and everyone who attended this webinar today. We hope that it was a good one for you. We post recordings of all webinars on the CTF website. If you go under the webinar tab, you will see all webinars, including the recordings. Now, after this webinar, you'll be asked to do a survey. We would appreciate your input, comments, as we always want to deliver the webinars that meet your needs. Now, last but not least, if you have any questions, please do not hesitate to send them over to me or Willem Lems at capturethefracture@iofbonehealth.org. That's capturethefracture@iofbonehealth.org. Now, on that note, I would like to thank Professor Willem Lems for your precious time and for your great presentation today.
My pleasure.
Now, thank you very much, everyone, and have a good evening.